Welcome to AETCM, the emergency medicine channel. Today let us discuss about the management of acute coronary syndrome in emergency room. When we discuss about the coronary syndromes, there are different types of coronary syndromes. Whenever some patient admitted to emergency room with acute chest pain, that is mostly because of acute coronary syndrome if coronary arteries are either completely blocked or partially obstructed. So when we have a patient who is having acute chest pain who come to emergency room, they have typical angina. Angina means left-sided chest pain that is radiating to left arm, left shoulder. There is angina. Along with the angina, patient can have sweating, palpitation, breathlessness, all these things. Normally we take an ECG. If the ECG shows ST elevation, that is called as ST elevation myocardial infarction or STEMI. If the patient is not having ST elevation, instead of ST elevation, if they have ST depression or T-wave inversion, deeply inverted T-wave, we call it as non-ST elevation problem. In non-ST elevation problem, if the troponin I or CKMB is normal, then we can call it as unstable angina. If the cardiac markers are elevated, then we can call it as non-ST elevation myocardial infarction. So there are two components here. Whenever we get a chest pain, we have two components. One is ECG. Most of the time ECG will show ST elevation. We call it as ST elevation myocardial infarction if there is elevation of cardiac enzymes. If there is no elevation of cardiac enzymes, there are multiple reasons like Prinzmetal's angina or normal variant or pericarditis. There are a lot of other causes also can produce ST elevation. Whereas chest pain associated with ST depression or T-wave inversion with elevated cardiac enzymes, it is non-ST elevation MI. If there is changes without elevation of cardiac enzymes, it is mostly unstable angina. So myocardial infarction means complete obstruction of coronary arteries, and that reduces the blood supply to certain areas of myocardium, and the part of the myocardium will die. It will go to necrosis. So that is myocardial infarction. You can see here in picture slowly the platelet rich plaque, that is platelet, cholesterol, fibrin, all these things form a plaque in the coronary arteries. Slowly the blood supply reduces. Suddenly one day the plaque may rupture or completely obstruct the blood vessels. That will lead to complete blockage of blood supply to some part of the myocardium. That part will die or necrosed. So that is myocardial infarction. So here we can again see ST elevation acute coronary syndrome or non-ST elevation acute coronary syndrome. In ST elevation acute coronary syndrome, the flow is completely blocked. The flow to myocardium is completely blocked and cardiac enzymes are elevated. Whereas in non-ST elevation acute coronary syndrome, it is partially blocked, and sometimes the block is very severe. Cardiac enzymes can be elevated. That should be taken as complete block itself. So that is a problem in acute coronary syndrome. Complete blockage or near complete blockage of the blood supply to myocardium, and that may kill the myocardium. The death of myocardium will be taken as myocardial infarction. During that infarction, cardiac enzymes will be elevated. Now this is ST elevation. You can see here first ECG is normal. You can take the PR segment. PR segment is after P to QRS complex. That PR segment is taken as isoelectric line or 0. If it is elevated from that isoelectric line, then it is ST elevation. ST segment elevation at the J point in two contiguous leads, like two leads like V1, V2 or 2, 3, 1 AVL, V5, V6 like that. Two contiguous leads with the cutoff points like more than 0.1 millivolt, that is 1 small squares, in all leads other than leads V2, V3. For leads V2, V3, the following cutoff points are applied: more than 0.2 millivolts, that is 2 small squares in men over 40 years, more than 2.5, that is 2.5 small divisions in men less than 40 years or more than 0.15 millivolt, that is 1.5 small squares in women. So these are the criteria to make diagnosis of ST elevation. Now these are the different time intervals changes seen in ST elevation. First A, you can see mild ST, then T wave is very tall, then ST is slightly elevated, ST again elevated to very near to the end point of T wave, then slowly T wave comes down, T wave inversion occurs, then deeply inverted T wave, then ultimately if the area is reperfused, you can get normal change. If the area is not perfused, that will be producing a Q wave. Q wave indicates death of the myocardium. So normally if myocardial infarction is not treated well, you can see Q waves. Now these are the causes for ST elevation or very tall T waves, like you can remember it as elevation. Electrolyte imbalance like hyperkalemia, left bundle branch block, early repolarization pattern, it's mainly seen in young thin individuals, it's a benign condition. Ventricular hypertrophy can also have ST elevation, or ST depression also can be possible. Aneurysms of ventricle, that is very important, because patients who have a myocardial infarction, if they are not treated properly, they develop ventricular aneurysm, and ECG may have persistent ST elevation more than 6 weeks. So ventricular aneurysms also can produce ST elevation. Takotsubo disease, infarction of myocardium, that is myocardial infarction, Osborn waves, hypothermia, non-atherosclerotic vasospasm, that is Prince-Mettels angina. In that, two important things we should remember. One is myocardial infarction and Prince-Mettels angina. Other important thing is aneurysm of ventricle. And one more important thing is the patient is having pericarditis. Pericarditis also can have ST elevation, but in that condition, in that type of ST elevation, you get universal ST elevation, whereas in ST elevation due to myocardial infarction, that will be seen only in a group of leads, like anterior wall ST elevation means anterior wall MI, inferior wall ST elevation means inferior wall MI, whereas pericarditis will have universal ST elevation. ST elevation will be there in the inferior leads, lateral leads, anterior leads, everywhere you can see ST elevation, and concavity of ST segment will be towards upwards. So that is a major difference between myocardial infarction to pericarditis. Non-ST elevations, you can see here in the fourth and fifth picture, ST depression and T waves are classically seen in non-ST elevation MI. Here there is no ST elevation, but patient is having typical chest pain and elevation of cardiac enzyme. One more thing you have to remember is patient who is having diabetes. So patient who is having diabetes, mostly they may not have chest pain because of autonomic neuropathy. They can have breathlessness. In that patients, if you do cardiac enzymes, sometimes it will be elevated. That also should be taken as myocardial infarction. So a patient who is having acute breathlessness and ECG shows some changes, and ST segment may elevate or depress, or T wave inversion can be there. But if the cardiac enzymes are elevated, then it is myocardial infarction. Now, new onset of left bundle branch block, that also should be taken as myocardial infarction. One important criteria, that is Carbosa criteria, that will tell you that LBVB indicates ischemic LBVB or not. Whatever it is, concordance pattern in LBVB, that is very, very important. That means you can see the first picture of ischemic LBVB, both QRS complex, ST segment, T wave, all are in same direction. This is called as concordance pattern. So normally LBVB you have positive QRS complex and negative ST segment, that is discordant pattern. But here you are getting all waves are in same direction, that is concordance. Other changes also seen here. So this is new onset of LBBB, that should be taken as acute myocardial infarction. LBBB itself is a ischemic change, but new onset of LBBB should be considered as new myocardial infarction. Now we can localize the myocardial infarction by ECG, like ST elevation V1, V6. You can see left anterior descending artery, like that. You can see where is the infarction in most of the ECGs. You can exactly predict which artery is blocked in myocardial infarction, like V1, V4, LAD, septal branches, 1 AVL, V5, V6, that is lateral MI, LCX and MO, 2, 3 AVF, 1 AVL, reciprocal changes, RCA and RCX. Like that, we can predict which artery is involved in myocardial infarction. So I am not going to the details of this diagnosis. Once you make a diagnosis of myocardial infarction, then normally from ECG or from history or from clinical findings, you have to see the cardiac enzymes. You have to send a cardiac enzyme or cardiac markers. They are normally we send CK, CKMP, troponin I or troponin T. Okay. So normally we can see CKMB is elevated in 4 to 8 hours and it returns back in 48 hours. That is very important. Troponin I rises in 4 to 6 hours, but it does not return back very fast. It takes 7 to 10 days. That is very important. So in reinfarction means a patient who is admitted with myocardial infarction, we do some procedure or thrombolysis, then patient improves. After that second day patient develops again chest pain. If you want to rule out a myocardial infarction, you cannot send troponin I because it is persistently elevated for the next 1 week. But troponin, whereas CKMB normally increases in the first day and comes down the second day, then again if it is increasing, then it is a reinfarction. So CKMB is the best test for diagnosing reinfarction in a patient who had myocardial infarction. Now you can remember the management of myocardial infarction with a mnemonic, that is MONARC. Morphine should be given for pain relief. Morphine 2 to 5 milligram can be given with antiemetic. Oxygen must be started only if there is hypoxemia, otherwise oxygen will be dangerous in a patient who is having myocardial infarction without hypoxemia. So oxygen should be started only if there is hypoxemia. Nitrates can be given, you can give sublingual sorbitrate or NTG infusion, but in myocardial infarction it may not relieve the pain because it's complete obstruction, whereas in ischemic heart disease due to unstable angina or Prinzmetal's angina, vasospasm will be relieved by NTG. Aspirin should be given. Whether the patient has taken the daily dose of aspirin or not, we have to give 300 milligram of crushed aspirin. It should not be ecospirin. So that is very important. It should not be an enteric-coated aspirin. We have to give a plain aspirin. Rest and relaxation should be advised. Patient should be counseled properly because they will be having anxiety, fear, all these things. Fear of death will be there. So we have to counsel the patient properly. Then continuous ECG monitoring should be there. Later we have to treat the patient according to the clinical problem. So oxygen we have discussed. ECG monitoring should be done. Morphine should be given 2 to 5 milligram. It's a sedative. It relieves the anxiety. Along with that, we have to give metoclopramide. That is very important. If you don't give metoclopramide, patient has severe vomiting after morphine. One more problem of morphine, it can produce urinary retention, it can produce constipation. So all these things should be taken care once the patient is given the definitive treatment of myocardial infarction. Angina, we can give sorbitrate sublingual, that may not work in myocardial infarction, but whereas unstable angina it will relieve, or we can start NTG infusion also, start with 5 microgram, increase slowly, maintain systolic BP above 90 millimeter of mercury, because hypertension we may not be, if the patient develops hypertension we will not be able to thrombolyze. Then aspirin, crushed aspirin not ecospirin. Dispirin is the ideal tablet, 300 milligram. Now there are different types of antiplatelets. We routinely give aspirin, 300 milligram, chewable or soluble tablet. Some doctors prefer clopidogrel, 300 milligram stat, then 75 milligram per day, or we can go for ticagrelor. That is a newer drug that can be tried. 150 milligram is given stat. Okay, so aspirin plus clopidogrel or aspirin plus ticagrelor. So these are the combinations should be given as soon as possible in emergency room. If we are thrombolizing the patient, you give clopidogrel. If we are going for PCI, that is angiogram angioplasty, use ticagrelor. Now, beta blockers are one important drug in acute myocardial infarction where the BP is good or normal. High BP or normal BP, we can try beta blockers. If the patient is having hypertension, bradycardia, asthma and all, try to avoid this drug. Metoprolol is a commonly used drug. 5 milligram IV can be given. Repeat the dose after 5 minutes. Wait for the response. One more dose can be given. Like that, 15 milligram can be given. The advantage of beta blocker, it reduces the heart rate, so that it reduces the oxygen demand of myocardium. So that demand will come down. So patient improves with that demand supply mismatch. From that point, it is very good drug. Cocaine intoxication induced chest pain with myocardial infarction. Beta blockers should not be given. Patient who is having heart failure, severe asthma, hypertension, bradyarrhythmia also we should avoid. So especially patient who is having inferior wall myocardial infarction, they can have bradycardia, they can have hypertension. In that condition, avoid beta blocker. Now, thrombolysis is one important part of myocardial infarction management. Nowadays, with tertiary care centers, most of the tertiary care centers have PCI capability, but even then some patients may not prefer PCI, and some centers there will not be any PCI. There we can still go for thrombolysis. So streptokinase 1.5 million units in 100 ml saline given as IV infusion, that is a commonly used drug. It is a very cheaper drug comparing to other drugs. It is cheaper, so that can be tried. Other drugs like Alteplase, IV bolus 15 milligram followed by 0.75 milligram per kg body weight, but not exceeding 50 milligram over 30 minutes, and then 0.5 milligram per kg body weight, but not exceeding 35 milligram over 60 minutes. IV Retiplase is another drug, 10 units over 2 minutes, then repeat 10 units bolus 30 minutes. Tenecteplase is the third drug. That depends on the weight we can give the drug. So streptokinase, urokinase, Alteplase, Retiplase, Tenecteplase, all can be tried. All these drugs have a side effect, that is bleeding tendency. So a patient who is having severe bleeding tendency or abnormal bleeding parameters, previous stroke, hemorrhagic stroke, previous surgeries, all these things we have to avoid this type of drugs. Now, once we thrombolyze the patient, we can see sometimes a lot of arrhythmias can be there. So in myocardial infarction, there are different types of arrhythmias, like you can get VT, you can get SVT, atrial fibrillation. So many arrhythmias are there. In that, one of the arrhythmia, that is benign arrhythmia, that is accelerated idioventricular rhythm. You can see wide complex rhythm. Heart rate is more than 50 to 110. If it is heart rate is very high, then we can call it as accelerated idioventricular rhythm, that is more than 100. If the heart rate is more than 100, we can call it as accelerated idioventricular arrhythmia. Here the heart, it's a regular rhythm, QRS complex is wide, rate 50 to 110 beats per minute, 3 or more ventricular complexes in a row. So that's a type of VT, or it is called a slow VT. There is no increased heart rate more than 110, it will not come. So it's a good arrhythmia. So whenever we thrombolyze the patient, if you are seeing this type of arrhythmia, that is a sign of reperfusion, but that is not very sensitive for reperfusion, so we cannot take it as a complete it's not a very good marker of reperfusion, but it is called as reperfusion arrhythmia. Now, anticoagulants, once we thrombolyze the patient, after completion of thrombolysis, we can start the patient on anticoagulation with IV heparin. So we can give 60 to 70 units per kg, that is 5000 international units maximum, followed by an infusion of 12 to 15 units per kg per hour. Initial maximum 1000 units per hour can be started. APTT should be 50 to 75 seconds. It should be continued at least for 24 hours. So we can try heparin after thrombolysis, or we can go for low molecular weight heparin like enoxaparin 1 milligram per kg subcutaneous, or fondaparinux factor 10 inhibitor 2.5 milligram subcutaneous OD. All these drugs are used to prevent propagation of the existing thrombus and prevention of deep vein thrombosis. They are not thrombolytics, they only prevent further accumulation of the thrombus around the existing block. Now, along with the other drugs, we have to start statins, that is lipid lowering drug. Whether the cholesterol is high or not, we have to start this drug because it has got two actions. It reduces cholesterol. Another action is plaque stabilization. So we start 80 milligram of atorvastatin or 40 milligram of rosuvastatin. Then reduce the dose to 40 milligram of atorvastatin or 20 milligram of rosuvastatin. We can add fibrates also depending on the triglyceride levels, or if the cholesterol is not getting controlled with routine statins, we can add fibrates. ACE inhibitors should be started for ventricular remodeling prevention. So in a patient who is having acute myocardial infarction, there will be thinning of the ventricle. Slowly that part will dilate and produce complication like aneurysm or other complication, reduced ejection fraction and all. To prevent that, we can start ACE inhibitor or ARBs. Along with ACE inhibitor or ARB, we can add aldosterone antagonist like spironolactone. All these three drugs have got similar action: ACE inhibitor, ARB and spironolactone. They all act on the problem, that is ventricular remodeling after myocardial infarction. It prevents the dilatation of the ventricle. Now, other interventions like we can, if the center is capable for primary percutaneous coronary angioplasty and angiogram and angioplasty, we can take the patient for that. Or sometimes if there is failed primary PCI, or if there is a strong indication for coronary artery bypass graft, we can take directly the patient for CABG instead of going for PCI. Sometimes the cardiologist may decide to go for CABG. That all depends on the clinical scenario. You can see here ED management of acute myocardial infarction. So we can remember all these things with like this. Stabilize the patient, oxygen if needed can be given, morphine can be given, we can give beta blockers and ACE inhibitors, aspirin, clopidogrel, ticagrelol, statins. Thrombolyze the patient. If no thrombolysis, take the patient for PCI. So these are the things should be done in ER. So we have discussed about one of the most common problem, that is chest pain in emergency room. Chest pain can be due to a cardiac problem. It can be due to a problem in the cardiac muscle, pericardium, or it can be due to a lung problem like pulmonary embolism, a problem in the aorta like aneurysm and rupture in the thoracic aorta, or it can be pleuritis, or it can be a skin condition like vesicles on the skin like herpes. So many differential diagnoses are there for chest pain. So whenever we get a chest pain, we have to take an ECG. If there is no ECG change at first 0 hours, then after 30 minutes repeat another ECG, see any changes are there. Even if there is ECG change, you have to see the cardiac enzymes to know whether the patient is developing myocardial infarction or not. ECG changes are there, cardiac enzymes are not elevated, then even we can repeat the cardiac enzymes after half an hour. Sometimes initial cardiac enzymes may not pick up myocardial infarction, and along with that we can give NTG infusion that rules out unstable angina, Prince metal angina, all these things, because myocardial infarction pain will not be relieved with NTG. We have to give morphine. Thank you.